Good morning. Hi, everyone. We'll get going here in a minute or so. My name is Sharon Duncan. I'm patient care coordinator and educator at the pre-transplant clinic at Vancouver General Hospital. I've had the pleasure of working with our next speaker, Dr. Olwyn Johnston, with the live donor transplant program at Vancouver General. Olwyn is a champion for transplant options, including the highly sensitized program and kidney paired donation. Her presentation today is near and dear to her heart. It's transplant options for patients, choices, and consequences. Olwyn?
Thanks, Sharon. Sure, I don't think this is working actually. Can you hear me? Yeah. Okay. I don't want to stand in front of this now. Is this working? Yes. So I have no conflicts of interest in relation to this talk. So the two main learning objectives for the talk today are to and I'm sure everyone in the room knows what's available at the moment, but just to reiterate the options that are out there at this very time for patients in BC for transplantation, and also to understand the benefits, the advantages, and the consequences of various transplant options that patients might be offered, and for advising patients about different transplant options and the consequences in their situations as well. So for everyone in the room, it's important that we start the talk off with all agreeing that transplant is the best option for the majority of patients who have end-stage renal disease. You've seen this slide a lot over the last couple of days, and this is fundamental to our knowledge of transplantation as a renal replacement modality. You can see from this graph here that, I'm sorry, I have a double kind of a clicker, but on the x-axis here is the time from transplantation, and on the y-axis is the risk of death. At the time of transplantation, there is an increased risk of mortality compared to the solid line, the dotted line here, which represents those patients staying on the waiting list, waiting for transplantation. However, within a couple of months, that risk is equalized, and very rapidly after that, and subsequently indefinitely after that, the risk of death is significantly lower for patients who get transplanted versus those who remain on dialysis waiting for a transplant. So really, transplantation, provided that we can make sure that the patient gets through this particular risk of initial transplantation, is much more beneficial to the longevity of the patient. So what are the options out there? So in BC, we have any option that's available across the country is available here too. So if we divide our options into deceased donor transplant versus living donor transplant, as you're all aware, with deceased donor transplant, we have two different types of deceased donor. There's neurologically dead donor, and these are donors who have reached the criteria for brain death. And then there's donation after cardiocirculatory death, and Jag talked a little bit about that yesterday. These are patients who haven't reached the criteria for brain death, but without life-supporting therapies will not live. So for deceased donors, patients can get deceased donors in two ways. They can be on the BC deceased donor waiting list, which, as you know, the clock starts ticking the day they start dialysis for waiting time. Those patients who we call highly sensitized, so those patients who have anti-HLA antibodies greater than 95%, so these are majorly disadvantaged patients, they also, we can consent them to be enrolled in the highly sensitized registry, which is the national registry for these highly sensitized patients. And they are automatically on the BC waiting list when they're enrolled in this as well, but this opens them up to the whole country, to donors, deceased donors all across the country. Now, the highly sensitized registry has been very successful for BC patients. Since it started, over 300 patients have been transplanted across the country who have been highly sensitized, who would probably still be on dialysis in their own province without this. And it is, and within those patients, about 12% have been 100% sensitized. So that means that they got an identical match within the highly sensitized registry. So the other option is living donor transplantation. So when we're seeing, sorry about this moving all the time, I'm not moving my hand. The living donor transplantation is always offered to all our patients when we see them. But the patient has to do some homework. So the patient themselves will have to outreach for that living donor. And living donor transplant, as you know, can be either preemptive or can take place when the patient is on dialysis. And I'm going to talk to you a little bit about the advantages, disadvantages, and the hierarchy of what's the better type of transplant in subsequent slides. So for living donor transplant, it can be either direct, if the patient is lucky enough to have a living donor who matches both blood type match and HLA match to the recipient. There's also direct, can be if they're ABO incompatible, we can do desensitization. It's usually not our first line. We usually, in that situation, will place people in the paired exchange registry first to see if they will match without desensitization. And then, of course, there's indirect. So indirect is when patients are either ABO or anti-HLA incompatible, and they are placed in the other national registry for matching nationally. And this has been very successful as well, and I'll talk a little bit about this later. Patients can go into the paired exchange even though they're direct match for each other as well. And Jag touched on this a little bit in his talk yesterday. So these are compatible donors who enter into kidney paired exchange. And this happens for several reasons. One reason is that the pair want to do maximum benefit from, particularly the donor wants to have maximum benefit from their donation. So by entering into the kidney paired donation registry, they are not only facilitating the transplantation of their loved one, but also they're facilitating other transplants within, other incompatible transplants within that as well. Other times, compatible pairs can be put in, or if there's a major age discrepancy between the donor and the recipient, it may be more beneficial for them to be entered into the national registry so that they get, the recipient gets a better age match, etc. So these are all the different types of varieties that we have. So looking at the transplant activity in BC, and if people were here yesterday, you would have got a flavor for this. So as everybody knows, we've had a huge increase in our transplant numbers in the last, particularly 18 months. Just to give you an idea, I've divided this into deceased donation and living donor transplants, and this is just to August 31st. You can see where there was 163 deceased donors at that stage. It's actually gone up to 181 since this week. And living donors 61 has gone up to 71 since this week as well. So already we have gone past, last year's deceased donor total, and we're definitely on for surpassing total numbers for this year. A few little things to notice from this. So with deceased numbers increasing, you can also notice that there's an increase in the donation after cardiocirculatory death numbers as well. And this is not even total year numbers yet. So this has had a big impact on our deceased donation. And of course, the mode of donor death has made an impact on our donor numbers as well. Unfortunately, living donor numbers are not increasing. So, and at best, they're kind of leveling out, but we certainly have seen a drop in in living donor numbers, and particularly living anonymous donors who've come forward. We've noticed a drop in that, and there may be an increase more recently, but certainly on the national level, there's been a huge decline in anonymous donors who are coming forward, and these are particularly beneficial for the per donation registry, as they are the ones that instigate domino effects in the paired exchange. So this is a little bit concerning, and this is why we're talking a lot this year about encouraging patients at an early stage to know that living donation is possible, and to be thinking earlier in the process about living donation. And I'll talk to you a little bit about differences in the benefits between deceased living in later slides. So looking at our deceased numbers, as I mentioned, this is brain dead donors, this is DCD donors here. And highlighted in the red-orange color is HSP. So you can see the majority of our highly sensitized patients get transplants from neurologically dead donors. And this sometimes is because a lot of those are coming from out of province, and we tend to be a little bit more conservative about allocating these. For donation after cardiac death donors, we do accept those from other provinces, but there is a very long cold ischemic time for organs coming from other provinces. And if they have donation after cardiac death donors in addition to that, there is a much higher risk of delayed graft function in the kidney. So you can see that, and as I said already, this has surpassed here. This is just August numbers here. For living donor numbers, as you can see, this is direct and indirect. The majority of preemptive transplants come from direct donors, and this makes sense because everything is scheduled and we can time it much better. However, we do have a lot of patients who get transplants preemptively from paired exchange as well. You can notice the drop in our numbers over the last few years of living donation. The paired exchange, though, has been very successful since it started. There's been over 560 transplants. The unfortunate thing is that over time, the more highly sensitized patients on that registry are accumulating. So about half the patients on the registry now are highly sensitized. But at the same time, we need those anonymous donors coming into that in order to move the numbers. So this is just to give you a breakdown. We're doing very well for preemptive percentages from across the country. In fact, we're probably one of the highest in provinces in the country. On average, it's about 35% preemptive per year. This year looks higher because our overall numbers of living donation are lower. So we've actually have the same almost numbers of preemptive, but our total number of living donation is a little bit lower. And then if you look at preemptive transplant compared to total number of kidney transplants that we do per year, it's only a small fraction, and it hasn't really improved over time. It's like 0.1% of total number of deceased living donor transplants, and it's about, as I said, 35% of total living transplants. Okay, so there are numbers. So when you're explaining to a patient about the different transplant modalities, they'll have several questions. They'll want to know how long am I going to be waiting? If I get a deceased donor transplant, how long is that going to last me? How long will a living donor transplant last me? And should I get my kidney before I go on dialysis? How is that possible, etc.? So here are some of the answers to those questions. So we saw this before. So you have to keep this in your mind all the time. So this is important to tell the patients. Oftentimes patients come to me and they think if they get the transplant, they're going to get rid of their diabetes. They're going to be able to go do the next marathon. They have very false expectations. So it's important to tell patients that transplantation will stop a lot of the risk factors they're developing on dialysis. And this is evident here because the longer you're on dialysis, the more you accumulate of cardiovascular risk factors, so your mortality is higher. So that's why this line gets wider as time goes on, because the longer you're on dialysis, your cardiac risk factors increase, and that increases your risk of death. So that's important for people to remember. So the sooner somebody can get a transplant and the less time they have on dialysis, the better their long-term longevity. So looking at deceased donor transplant first. So we know that transplant is better than staying on dialysis. Is there a difference between patients who get patient death between getting a expanded criteria donor, that's what ECD means, over dialysis? So if you get a kidney from an older patient who may have had controlled diabetes or controlled hypertension, may have died from a stroke, their creatinine is not perfect. Am I getting a second-rate deal here, or is this still a benefit to me? So you can see the same graph looking at this type of patient. So they do get a benefit. So getting off dialysis is always a benefit. So these type of kidneys, so as you know, we age match. So over 60 kidneys will be offered to over 60 patients on the wait list. So these are the patients we really need to get off dialysis because their mortality is much higher as well. So you can see where the equalization risk is a little bit longer after transplant compared to transplant in general for these kidneys, but overall long term there's a significant difference in patient survival getting transplanted. And more recently in the US, they, instead of using extended criteria donor, they describe it by using an algorithm called the Kidney Donor Profile Index. And this looks at both donor characteristics and recipient characteristics, and it gives a percentage of an index. And the higher that percentage is, the more risk factors both the donor and the recipient have. So you would expect the outcomes to be worse. And you can see here where the different categories of KDPI are here. In the green is the highest category. So these are the most at-risk patients who are, and even in those patients, you can see where their mortality risk is high at the time of transplants. The time of equalizing risk to somebody who's on dialysis is longer than somebody who gets a lower risk kidney and is a lower risk patient. But overall, there is still a significant difference in patient mortality afterwards. So the next question is there a difference between getting a neurologically dead donor versus a donation after circulatory death? So the answer is no. Long term, there's no difference. Certainly, immediately post-transplant, DCD donor recipients have a higher risk of delayed graft function because of the cause of death of the donor. There's a longer warm ischemic time, a longer cold ischemic time, but long term, there is no difference between survival between the two. So the red and the yellow lines here are the standard criteria donor kidneys from both brain dead donor and DCD donor. So you can see it's just they overlap each other. Similarly, between ECD brain dead donor and DCD donor, they almost overlap. There's no significant difference there. There certainly is a difference between ECD and standard criteria donor, and this has a lot to do with the age of the recipient as well. So we looked at transplant versus dialysis. We looked at deceased donation, the different types of deceased donation and their benefits. So what about living donor transplant? So is there a benefit of living donation over deceased donation? The answer is yes, and there's several benefits, and I'll go through them now. So one of the most important benefits is survival. So you can see here, this is BC data, and it's looking at the survival of the graft. So how long is my kidney going to last me? So it lasts longer in living donor transplant. So you can see here, looking at 5 years, there is a higher graft survival compared to deceased donor transplant. And this is more obvious actually in the older age group, as you can see here. This is one of the fundamental advantages. Looking at Canadian data, we actually do better in BC than Canada in general. The survival rates are a little bit higher in BC than in Canada overall, but it's similar right across the country. So living donation, the kidney lasts longer. And people often ask, how long does it last for? And that's a really tricky question to ask. I can't give a time because it all depends on donor factors, it all depends on recipient factors, and comorbidities of the recipient as well, recurrence of disease, et cetera, et cetera. So that's very difficult to say, but overall, when you're looking at populations of living donor transplants versus deceased donor transplant, the kidney lasts longer. So what's the other advantage of living donation? Well, the other advantage is time. With living donation, if particularly somebody has a direct donor, then everything can happen really fast. So a lot of the delay in living donation is because of the donor workup, because we cannot be putting pressure on the donor to get their workup done. They have their normal life to lead and they get their workup in their own time. And sometimes it takes them time to get around the idea as well of donation. And so they might just stagger their workup a little bit because they're deciding on whether they want to proceed with this or not as well. But if a living donor is approved and the recipient is approved, then there's no delay in surgical date. They will be able to get a surgical date within a month or two. And if they're preemptive, we prioritize preemptive. So if the patient hasn't started dialysis yet, they will be prioritized in the surgical schedule as well. Now, for deceased donation, as you heard, our waiting times have got less. So this is looking at patients who are not highly sensitized in BC for the various age groups and for the various blood types. And this is kind of our most recent data. So if you look here, if somebody is, for example, blood group A and over 60, they may just wait 2.5 years if they're not highly sensitized. And similarly, for blood group AB, the waiting time is, you're talking a year or less for all age groups. For blood group O, there's a big advantage for younger people, about 1.9 years. But we have seen a huge difference in the waiting times for both A and O. Unfortunately, B have not had much advantage with our recent surge in deceased donation, which is a problem. So it's important for the patient as well to know their blood type and to know the options that are available to them, because if they're blood group B, then they need to know that they're going to be waiting a long time on dialysis before they get a deceased donor transplant. Now, even though these times are really good, and if the patient is not sensitized, that's fantastic. These will be their times. But at the same time, living donation is a superior type of transplant to get. So we could be lazy and say, okay, our deceased donor numbers are really good, so let them just wait for deceased donor transplant. But avoidance of dialysis altogether and the shortest period of dialysis at all is a major advantage to the patient. And I'll show you a little bit about more preemptive in a few slides. So this is a kind of a good slide to remember. This is people who are zero PRA. So these have no sensitization at all. So at this very time, this is we're transplanting people with these dialysis start years. So for blood group A, we're transplanting patients who are zero PRA who started dialysis 2015. For blood group AB, it's this year or last year. And similarly for blood group O is 2015. But you have to remember that these are people who have no sensitization at all. So if they have any type of sensitization, it may delay them on the waiting list. And for highly sensitized patients, I haven't even given a timeline here because they could be waiting a month, or they could be waiting 20 years. So that's really unpredictable. So other advantages of living donation. So what we see a lot is over 60 patients when they're coming for assessments. Their family come with them. The patient themselves says, oh, I don't want my family giving me a kidney. And I'm willing to just wait it out on dialysis to get a kidney. But we know that for elderly people, their mortality is so much higher at the time of transplant, and it's so much higher the longer they're on dialysis. And our group here have done a lot of work on looking at the advantages of living donation in elderly. So here is elderly, so low risk, intermediate risk, high risk, and I mean cardiovascular risk. And then when you look at the orange line here is living donation. Staying on the wait list is the straight line. Purple is getting a standard criteria donor, and green is getting an ECD. So you can see that there's not much difference between SCD and ECD for the low risk group, but there's a huge advantage in getting a living donor transplant. They actually don't even have this big surge of mortality around the time of transplant. You can see that they actually have the advantage from the very beginning. So this is something that I always stress with patients. I tell them that the older they get, the higher their perioperative mortality and mortality immediately after the transplant. And for living donation, it negates that risk, particularly if they're low-risk patients. Even if they're high risk, you can see here where there's only a tiny increase in mortality compared to the wait list at the time of surgery. For living donation, it's far, far higher with deceased donation. So this is something you need to bear in mind, and their family needs to know this as well, that living donation is a huge advantage to the comorbidity and mortality of that patient. So in the obese, we talk a lot about, people need to lose weight for surgery, etc. We have kind of pushed the envelope a lot on what weight is acceptable for transplant over the last few years. 6 years ago, we were restricting BMI for transplant, but now we're not, because a lot of new evidence has come out. And again, our group has looked at this. So here is living donation, standard criteria donor, and ECD. And in the colors are the various BMIs. So in the yellow is BMI greater than 40, and in the purple is very low BMI. So it kind of ranges from that. So you can see for living donation, there is a huge advantage for everybody, particularly those people who are morbidly obese. You can see that, for morbidly obese, the risk at the time of transplant is so much higher than those who have a normal BMI. But for living donation, it almost negates that. So for somebody who's obese, I would always tell them to try and get a living donor, because their risk for any type of surgery is huge. But with living donation, because of the type of surgery it is, because the kidney works straight away and there's much less complications, those people do really well. And these people who have a morbid obesity, they're never going to have a BMI of 20. So you have to be realistic. And from our point of view, when we're assessing them, certainly we advise them to try and lose weight. And we say, we'll be looking to see if you're actually making grounds in losing weight, but we don't give them unacceptable cutoffs. And as long as they're making an effort, we understand that when they're on dialysis, it's very difficult to lose weight. So we know the advantage to them of getting a transplant. They will live longer than staying on dialysis if they're morbidly obese. Okay, so looking a little bit more preemptive transplant. So what are the advantages? And you've probably heard me talk about this before, but certainly I'm going to reiterate it again. So there's huge survival advantages to preemptive transplant. So what is preemptive transplant? So if we go back a little bit and think about the different transitions for these patients, and they all go through the cycle maybe once or twice in their lifetime. So the patient is diagnosed with CKD, it progresses, they go on dialysis, they get a transplant, eventually their transplant may fail and they go back to the whole circle again. So for preemptive transplant, we want to go from here, so progressive CKD, straight to transplant and take out this transition of dialysis. Now, a lot of studies have shown that various transitions from, from here to here to here to here, that has a huge impact on the patient. And they will tell you that, from going from, they have a different care team, they may have to go to a different clinic, they have to get access. There's a huge transition. So if we can take out one of those steps, that has a huge impact on the patient's quality of life. And also for staffing, for economics, for everything. So one of the main advantages of preemptive transplant is survival. So patients will live longer. So here you can see the years on dialysis on the x-axis and patient survival on here. So this is 0 years in dialysis. So these are the preemptive patients, and you can see their survival is superior. And every year that you're on dialysis, your survival goes down. And we all know this. And this is highlighted in a different way here. You can see survival here. And this is time post-transplant. So if somebody is transplanted, their survival after transplant, getting a preemptive transplant, is much higher. If they're on dialysis for 1 to 2 years, it's not too bad. But if they're on dialysis for 3 or 4 years, even at 3 or 4 years and longer, it keeps going down, down, down. So this study is kind of a bit blurry, so sorry about that. This was a very nice study because it looked at kidney pairs from deceased donors. So it looked at those kidney from one donor. One kidney went to somebody who was on dialysis 0 to 6 months, and the other kidney went to a patient who was on dialysis greater than 24 months. So this was retrospective analysis. And it showed that the actual survival of the graft was significantly lower in those patients who had been on dialysis for more than 2 years. So these are kidneys coming from the same donor. So it's not donor reasons, it's recipient reasons that are causing the graft to not last as long. Oh, sorry. So we did work here a couple of years ago looking at failing grafts to see if preemptive had the same effect on preemptive grafts. And it does. Preemptive transplant in a failing graft shows significant survival of the next graft. So if somebody has a GFR that's dropping, we usually tell them to start looking for living donors. And it's difficult in this patient group because failing transplants, they know what's ahead. They've been through it before, and they're very reluctant to undergo any renal replacement therapy because they're in complete denial that their kidney's failing. But if we tell them that if they get transplanted before they go on dialysis, that everything will go better for them, then they may start looking for living donors. So other benefits. So I mentioned about the quality of life. So this is a huge thing because, we as clinicians, we think of numbers and survival, etc. But to the patient, the quality of life is the most important thing. Are they going to be able to work? Are they able to go back to their normal routine? And this is a huge thing. So preemptive transplant is a superior modality for that because dialysis is taken out of the equation. So a lot of studies have been done on this, and it shows that if you can take out some of these transitions out of a patient's like CKD life cycle, that has a huge impact on their quality of life. Cost is the other thing. So this kind of goes without saying. This is US data, so it kind of is different from Canadian data. But what they looked at here is the cost savings at 2 years from patients who got transplanted preemptively versus those who were at least a year on dialysis before their transplant. And there's about a 35% savings at the 2-year point. And this makes sense because this whole chunk of expense here, the dialysis chunk, is taken out. And also expense to the general economy where patients are continuously working and they may have a gap of only 3 months versus several years if they're on dialysis. So patients on dialysis for more than a year, about only 24% return to work after transplantation. This is US data. For preemptive transplant, about 50% return to work post-transplant. The duration of disability before transplant influences return to work rates and family dynamics. And this goes without saying, but it's also confirmed in studies. Other benefits are no dialysis access for preemptive transplant, and then reduced infections, less comorbidities, less hospitalization rates. So there's a lot of overall health benefits. So we heard this morning about children. So it's important to think about children as well. So preemptive transplant in children improves their growth. They don't have as much problems with growth. The rejection rates are also reduced, and there's fewer sensitizing events. So these events that cause people to get highly sensitized because they don't get as anemic, and there's a lot of ramifications. They have reduced cardiac risk factors, so reduced cardiac systolic dysfunction, and again, overall hospitalizations are reduced. This is Canadian data from the annual report, Core Annual Report 2016. And for all the patients who reached end stage, the rate of preemptive transplantation nationwide was 2.9%. In BC, it was 4.9%. This has actually improved since this data was published. But we're not doing bad in BC, but we can do a huge amount better. And the way we can do better is that we know from our data here in BC that there's a lot of patients who get a living donor transplant within the first year of dialysis. So you might question, well, if they were able to get it within the first year of dialysis, we could have set this up so that they had their donor ready before they even went to dialysis. So they're the people that we need to talk to and we need to give education about, because that can be avoided. That dialysis could be avoided, and all the implications of dialysis starting could have been avoided in those patients. So as I said, in BC, about 37-ish is our rate of preemptive transplantation. Certainly we can improve on that. But we're not doing bad overall. In the US, on average, is less than 30%. Oh, okay. Interact with cases. I'm not sure how this is going to work because I don't have somebody to set it up. But anyway, we'll go through it and we can always talk. So these are real people. So MN was a 76-year-old man. He's blood group B. He's fully functioning. Even though he's 76, he likes to travel, he has 3 grandkids, and he likes to hang out with the grandkids. He has stage 5 CKD, and his creatinine is like 350, his GFR is 14. So the question is, first question, oh, maybe I can get into this. First question is transplant the best renal replacement modality for him? And please give the right answer to this one. Oh, I don't have internet, actually. It tells me I don't have internet. Oh. Okay. Sorry, I don't have the internet. So hands up. Yes or no? Hands up for yes. Thank you. Okay. So is there any no's? Is there any no's out there? No. Nobody will know. So the second question is, what kidney transplant option would be the most favorable in his case? Would it be number 1, deceased donor transplant, number 2, living donor transplant after starting dialysis, or preemptive living donor transplant? 3. Okay. And the reason being that he hasn't even started dialysis yet. He's blood group B. So deceased donor transplant would not be an option for him anyway. Living donor after starting dialysis, you will be talking about 7 years once he starts dialysis. So preemptive living, and he's very functional, so that will be much better for him. So case 2. So OP, a 24-year-old female. She's blood group O. She has a CKD secondary to reflux nephropathy, has had a rapid decline in her renal function, and her GFR is now 17. She is very functional. She's working full-time as an accountant. So I hopefully don't need to ask you this question. And the second question then is, so what kidney transplant option would be most favorable for her? And I give the same indications. So 1, 2, or 3? 3. Okay. These are too easy. So CN, they're getting a bit harder now. So CN is a 55-year-old female. She is blood group A. She has end-stage renal failure secondary to diabetes. Started dialysis in March of this year. BMI 34. She's had several pregnancies, multiple blood transfusions. So things are going on in your head, I know. So this is not as easy. So yes or no? Yes. Okay. So the second question is the similar. So should we list her just for deceased donor transplant, living donor transplant, or list for both? Both. And you're correct. I mean, the reason being is that she is probably more difficult to match because she may be sensitized with her blood transfusions in pregnancies, and she's also blood group B, yeah, A, blood group A. She's probably sensitized, and her BMI as well. So you hope that she's going to get a living donor transplant. Okay, next one. So PG, a 60-year-old male, blood group A, end stage from hypertension. He already had a preemptive living donor transplant in 1999, but now it's failing, and his GFR is 19. He's had multiple, and that's because he had multiple acute injuries to his kidney. He's 99% sensitized. So, and he hasn't started dialysis yet. So, okay. So which one is the best for him? 3 ideally, but it might be difficult to get a donor that matches. But that potentially, if he does get a living donor, potentially he could go into paired exchange and may be lucky enough to get matched before he needs to go on dialysis. Okay. So take-home messages. So I think from your answers, I know you've got the take-home messages already. Kidney transplantation is the best renal replacement modality. It has superior graft and patient survival compared to dialysis. So keep that graph in your head all the time. Living donor transplant has increased survival compared to deceased donor transplants, and particularly in the high-risk population. So if you think of the elderly and the obese, it also has scheduling benefits over deceased donor transplantation. And preemptive transplant is the penultimate. So that's what every one of us would like to get if we were in this situation. Increased survival, increased health, quality of life, economic benefits over getting a transplant and you've already started on dialysis. So where do we go now? How do we improve things? So information, education. So that's what we hope to be able to roll out with our Transplant First initiative. And David talked a little bit about this yesterday. It's important that we talk to our patients early. So at the time that we're giving them CKD education, we need to be able to tell them about the different types of transplant available to them, their benefits, looking for living donors. As a follow-on to that, I'd like to introduce Carlin Jarvis, who's going to be, do you want to stand up, Carlin? Carlin is just changed her role. She's going to be now only half-time at VGH. She's our social worker for the Living Donor Program at VGH, and has been fundamental in giving all our patients such good information when they come down for their assessments. Now she is going to be And now she is going to be going around to all your centres, talking about what I've talked about here, as well as giving you advice into how to help the patients broach this subject of getting living donors, outreaching for living donors, giving, helping them with sample letters to distribute, etc. And so Carlin starts on Monday. Tuesday, yeah, Tuesday. So thank you for your attention. And if anyone would like to ask any questions, please feel free. Do you have a question?
Yeah. So I'm working in Fraser Health, specifically transplant program, and I get a lot of patients coming in, obviously not using free nutrition and living under the donation. Can you give us any clear-cut exclusions for donors? Because I've got, I'm 76, my older brother wants to donate to me, or I want to donate to my husband, but I can guess the BMI is probably 45 as a potential donor, and I, following my previous program, I never say no. I say contact the donor program. But I mean, usually I say, but it's not likely, and you should continue to look further. I've got a lot of people with very unrealistic donor expectations. I mean, I know you can't make clear cut.
Yeah.
We had clear cut. We didn't accept donors with BMIs of 30 to 35. We didn't accept diabetics. We didn't accept hypertensive. But in some programs do. This is often told on each.
So there's we nationally we published last year acceptance criteria for living donors that are acceptable right across the country, because each of the donor centres across the country, we have to actually be on the same page, because a lot of our donors will go to other centres and paired exchange, etc. So we got together and we put down kind of pretty conservative acceptance criteria. But I can see where you're coming from, because patients will tell you about their relatives and their problems. So there's no upper age limit to a donor. Some donors we see who are in their mid-70s are much healthier than 50-year-olds. So there's no upper age limit depending on their health. Certainly, if patients require treatment for diabetes and have ongoing diabetes, that's a contraindication. Hypertension we do accept if it's well controlled by 2 agents actually, but it has to be well controlled. There has to be no end organ damage, and we do all those testing when we're working up the donor. BMI, so nationally accepted is a BMI less than 35. But with that comes the caveat that they may have other metabolic abnormalities coming with the higher weight, like high cholesterol, pre-diabetes, etc. So, we talk to them about that and we assess them for that also. There are certain contraindications. People go through all their testing and they end up just having one kidney on their ultrasound when we do it at the end. These kind of things, even though their function is fantastic.
Would it be possible to put them in BC Transplants had a lot of great resources for professionals on there?
We put that publication on, certainly. That's a really good idea. Yeah. Somebody asked a question. Yeah.
I just want to know what your interventions on explore more about highly sensitized patients. So what explanation do you give to them when they come back from pre-screening, and then they'll tell you they have all this X number of blood transfusions, which will probably contribute to that outcome. And so how do you explain that? Because they have conversations with the patients and they say, oh, I may not get a transplant because I have lots of transfusion and all that. So
Yeah. When I'm explaining it, I usually explain it on a very positive side, like, glass half full rather than empty. Because now we have the advantage of having the highly sensitized registry. Up until we had that, it was a major disadvantage and it was very negative, what we had to say to people. So, and people and recipients find it hard to understand the whole concept of developing these antibodies as well. Usually I describe that they have developed antibodies to people who, if they have exposure in the past, and having a blood transfusion means you've had exposure to another person. Having a kidney transplant means you've had exposure to another person, pregnancies, etc. So I explain to people, I say, some people have 100 units of blood and don't develop any antibodies. Other people have a drop of blood and get 100% sensitized. So we have to do that PRA test in order to figure it out. And then I just sit down with them and talk to them about their percentage PRA. And, you know, if it is 95%, that actually is not as bad as 100%. So in the highly sensitized registry, people who are 95% sensitized get transplanted pretty quickly. It's the people who are 99.9% who need the exact match. They're the ones that are very disadvantaged. But just this week we had somebody who was 100% sensitized who got a transplant with HSP. So with the highly sensitized registry, they're exposed to the genetic makeup of a whole nation rather than one province, where there might not be similar ethnic mix to them. But if you take a whole country into consideration, they have a much higher chance of getting somebody who's like them to get a donation. So I think it's, when you're explaining it to somebody, it's much better to explain it on a more positive side, that we've had over 300 patients who were like you, who were transplanted nationally with this registry. And that would still be on dialysis here.
My question is about type 1 diabetes. Are people automatically referred for pancreas after kidney? Like, if we have kidneys, we don't necessarily treating them in that question. But would that push like complication automatically happen? And also, would long-term high A1Cs ever be exclusion criteria? Like if they're like we've seen for 2 years and you're still referring them to you guys with A1Cs of 14.
Oh, well, that's even a more reason to refer them to us. If they have brittle diabetes, that would be an indication that they really need to get transplanted, because that will have a huge impact on their comorbidities long term. People who have type 1 diabetes, they are referred to us for a combined kidney pancreas transplant. And patients at the moment, because of our high donation rate, people are getting their kidneys quicker than waiting for a kidney pancreas, because not every donor will be able to donate their pancreas. If there's a traumatic cause of death, or if it's from an older donor, they don't accept pancreases. So usually if somebody, and these are usually young people. So if somebody comes who is type 1 diabetic, I always say to them, get a living donor for your kidney, and then wait for your pancreas. And because that will get them off dialysis, because a diabetic person on dialysis is a complete disaster because their cardiovascular risk is huge. So we need to get them off dialysis. So they get a living donor kidney, especially for a younger person, that's much better. And then we list them within a year of getting their kidney transplant, they're listed then for pancreas. And in the meantime, we keep really tight control of their diabetes in order to protect their new kidney. Hi. Yeah. So there has to be a waiting period of time between the last dose of rituximab and transplantation, because it interferes with the cross-matching, and also it makes them more immunosuppressed to getting viral infections at the time of transplant. Some biologics are fine. So biologics that people use for Crohn's disease, etc., will not interfere, but rituximab affects the B cells, so that will interfere. So it's not a contraindication to transplant, but certainly there needs to be a period of time that they need to have disease-free off the rituximab before they could be transplanted. The fact that you're telling me they're on rituximab means that they have active arthritis or active vasculitis, which would be a contraindication to an acute transplant. So they usually disease-free after the treatment for a year. And we monitor their serology as well. So for example, if it was ANCA, we measure their ANCA levels, and if their disease is quiescent for a year, because there is a high chance of recurrence if they have active vasculitis at the time. So, for example, with ANCA, it has renal implications as well. There's also a higher chance of rejection at the time of transplant if they have vasculitis because their immune system is ramped up. So we have to be careful. Pardon? Yeah, yeah. There's a question over, yeah.
We're talking about a lot about living donor. It's kind of like thinking whether if the patient is seeking for living donor in the family or because it's more close or even the elder ones are looking for their next generation or whatsoever. So whether that will create some family dynamics because it's a burden to think about it. Of course, the donor, the kidney after that, we will have a little bit of risk afterwards, and also the culturally, some culture doesn't even thinking about it or they are hard to accept.
Mm-hmm.
That way,
yeah. So we see a lot of that because a lot of our population are from ethnic groups that living donation is not even considered. So that's why education is important. So we have to make a cultural change. From what you're saying about the generation and the family dynamic, it actually causes more family angst when the sons and daughters want to give and the parents won't take. That actually causes more problems than the other way around. It's usually the family who really want to give, and it's the potential recipient who doesn't want to take. They think that that it's not a good thing for their family, but living donation is safe. There are risks. It's surgery and it's in a healthy person, but we would not be doing this if we were going to we don't harm healthy people. So, and they go through much more workup than the recipient goes through in order for us to know that they're going to be healthy for that their kidneys are going to be healthy for the rest of their life. So for donor workup, it's very thorough. It's much easier for us to work up a donor who is older than a younger donor. So somebody who comes in their 20s as a potential donor, we're always nervous about because we don't know how they're going to be in 40 years' time. There's certain tests we can do to see their potential, but there's a lot of life events they haven't gone through yet that potentially could affect their kidneys, for example, pregnancies, etc. With one kidney, that could be a problem. But for somebody who's coming, like a spouse that's coming, we have enough tests to be able to figure out if this is going to be a problem or not. And we never put people at risk. Usually donors are the ones that want to go ahead and we say no. Was there a second part? Oh, the ethnic thing. So the ethnic thing, and this is a big challenge for you, Carolyn, is a difficult one. We see that younger generations of kind of Asian populations that have been born here in Canada have a much different kind of outlook on this than their parents or their grandparents. And that's why there's a little bit of angst between the generations on this. But certainly I think if people get more education and it's repeated several times during rather than when they just come to see me, that's very beneficial. And they've already kind of thought about things and it's reinforced. And if it's reinforced the same way by different people, I think that's going to be really helpful. Yes?
What would have a potential living donor, or if they're not a match, when you need a donor paired exchange, but you're not from the province, not from this country, not from this organ?
So we have all sorts. We've seen all sorts. So if they're not from this province, they're worked up in the other province the same way as we'd work them up here. And their workup is all done. We look at their workup and they come a couple of days before the surgery and we do the surgery here. If they're coming from out of country, it depends on what country they're coming from. So there's certain things that we need to know before they actually come here. So we need to know they have to be direct. If they're coming from outside Canada, they need to be a direct match for the donor. They won't be entered into paired exchange. It's only for Canadians living here in Canada. So if they're coming from outside, they need to be the compatible blood group, and number one, and good kidney function. So we get them to do initial blood work wherever they come from, just to make sure that their kidney function's okay and that they're a compatible blood group. And then if that looks okay, then potentially they can come here and get the rest of their workup done. But there's always a chance that something comes up that they're not a donor. So there's always that risk, and we have to reinforce that risk with them. There's other like, for example, there's certain countries that they do the full workup in. For example, if it's the UK or Australia, you know, where they do similar kind of workup to the way we do here. In the US, they have to pay for everything, so they tend to just do the minimal amount. But it depends on where they come from. If they come from places that we're not sure of kind of what kind of workup they get, we just repeat everything when they come here. Does that answer your question? There's a lot of logistics involved. There's immigration, there's delays, there's how long am I going to stay? Am I going to do the donation while I'm on this visit, etc. So, the workup for donation is actually covered under the recipient's care card or MSP. But if people are coming from outside the country as a donor, we need to have assurances that their follow-up in the country they go back to is adequate, that they have a family doctor, that they're going to get the surveillance that they need for future health as well. So that's one of the stipulations. I think we're time. Oh, one more question. Okay. Yes. So over the last probably 5 years, the anti-rejection medications haven't changed much, but certainly with the regimens that we use now, the acute rejection rates have drastically decreased compared to 5-10 years ago. Our rejection rates now are probably around 10-12%, compared to like 50% with old regimens. And that has an impact on long-term graft survival. We haven't quite, and the main thing that's under study at the moment is long-term graft survival from things like kind of chronic rejection. And the main cause of graft loss now is people are living longer with healthier kidneys, but their kidney is very gradually over time getting more fibrosis. So, and that's not directly an effect of the anti-rejection medication. That's a lot of other things on top of it as well. So we have certainly conquered early complications of transplantation with the anti-rejection medication we use now, but long-term, particularly chronic rejection, is a major problem. We don't have treatments for that. Okay, I think we have. Yeah. So can I just, sorry, Sharon. No, so can I just say for, there's a break now until 11:30, and then early lunch, brunch is at 11:30, and there's lots of prizes and everything during lunch, so make sure to go back into the main room again. Thanks very much.